Good morning, everybody. My name is Munir Mohammed. I'm Director of HDR UK North. Welcome to Stream C, a session which looks at how data has enabled research into the COVID vaccines. And we've got three fantastic speakers to take us through some of the work they've been doing and some of the highly novel, innovative approaches they've been using to be able to look at this. And I'm going to introduce them one after the other. And then we're going to have discussions at the end. So I'm going to go straight into the first speaker, and that is Professor Aziz Sheikh. Aziz comes from the University of Edinburgh. He's director of the Usher Institute. And Aziz is going to tell us about work he's been doing on safety and vaccine effectiveness as well. And in the EEVE-2 cohort that he's been looking at, EEVE-2 study. So Aziz, please, thank you.
Thanks very much indeed, Munir, and I'll just share my screen. So hopefully you can see that okay.
Yeah.
Yeah, great. So thanks very much for the invitation. It's absolutely fantastic to have the opportunity to present on behalf of the EEVE-2 and DAC-VAP investigator team. The latter is a UK-wide consortium that's come together, and it's great to be joining Paul and Julia on this panel. So I want to just begin by just highlighting a few conflicts of interest. I think it's important that people are aware of these, just to emphasize all these roles are unremunerated roles. This work has been powered by the HDR UK Breathe Hub, which I have the privilege of leading. This is, again, a UK-wide initiative, and what we're trying to do is make data discoverable, improve those data, and then use those for all sorts of purposes, whether it's public, commercial, government. The Breathe Hub, with permission of Andrew Morris, pivoted to try and respond to, help respond to the COVID pandemic for obvious reasons. So I want to kick off by talking briefly around EEVE-2. So EEVE originally was funded at the time of the H1N1 pandemic. So this is back in 2009. And really the kind of assumption here was that routinely collected data are absolutely fundamental to pandemic responses. With resources from the Chief Medical Officer at the time, Sally Davis, we put EEVE into hibernation following the end of that pandemic. And then we brought it out with resources from UKRI, and then it's been supplemented with funding from HDR UK, ONS, and the Scottish Government. And really what we've been trying to do is do three things. The first is to track the epidemiology of COVID-19 in Scotland, and been using this for forecasting. And so this is fed into Public Health Scotland, Scottish Government Advisory Group, SPI-M, so that's happening on an ongoing basis. The second is risk stratification. We worked in particular with Julia Hipsley-Cox, who you'll hear from later, in her team to validate the Q-COVID risk algorithm that's been used to identify those at highest risk of hospitalizations and deaths from COVID-19. And the third, and that's what I want to focus on today, is really beginning to look at the effectiveness and safety of treatments in particular, and preventative interventions, in particular vaccinations. So just to go back, I mean, we began that work with EEVE in 2009, but it was only in 2012 that this output was released. So it was, I mean, academically an important contribution, but policy-wise made next to no contribution really, because it took a long time. But I think things have changed. And so what we now have in EEVE-2 is really it's scaled up. So this is the entire population. It's linking primary care, hospitalization, testing, vaccination, mortality data across the entire population. So one of a few examples in the world of an end-to-end whole country scan of what's happening in their real time. This was the first output where we tried to estimate the effectiveness of the available vaccines in the UK. So Oxford, AstraZeneca, and BioNTech being used. And what we were able to demonstrate was that the signal being seen was broadly equivalent to that in clinical trials. But I think what we were also able to see was that the vaccines were proving very effective in the elderly who were excluded or not really included in the original trial. So, you know, an early important contribution that many of you will have seen. So I'm not going to sort of dwell on that for very long. The one I want to focus in on today is the Delta variant of concern, because this is obviously incredibly important. So this we released last Monday in the Lancet. We released it to coincide with the Prime Minister's statement and the First Minister's statement for Scotland, which was on the Tuesday. But prior to that, we'd made data available to, all relevant government bodies, MHRA, JCVI, the chief scientific advisors, CMOs, etc. Really what we've been able to see in Scotland is that the Delta variant, and that's in the pink, there has just taken hold so incredibly rapidly across the entire population. We've been able to begin to characterize the demographics of this, and so what we're seeing is that, and this is the Delta here is the positive S gene variant. We're seeing it predominantly in younger people. We've been able to, also look at this by socioeconomic profile, and again, we're seeing this mainly in the more affluent populations. On the bottom right is breakthrough infection. So most of these cases that we're seeing are in those who are unvaccinated, but as you can see, we're beginning to see breakthrough infections, and these are particularly in those with the Delta variant. So these are those who had 2 doses of the things. In terms of making this data available to government, we were able to then feed this into our forecasting work. And as you can see, in Scotland, again, we were in this phase of increasing number of cases. And here what's being demonstrated is admissions, and that was a kind of key concern here. In terms of risk of hospitalization, what we see is that with the Delta variant, there's approximately 85% increased risk in hospitalization across Scotland. What we're also seeing is that the vaccines do work, but it takes longer compared with the Alpha variant for the vaccines to begin to have their maximum effect. Last thing I probably want to just say on this is that we also employed a test negative designed to look at the protection against infection. And what we're seeing is when compared with the Alpha variant, which was dominant previously, vaccines are still working, but both these vaccines are working less effectively. So there's about a 13% reduction in the risk of protection against infection. And this all fed into the decision to extend lockdown restrictions, hopefully with a view to give more time for vaccinations to take place. The last example I want to just mention briefly is work that we've been doing, and this was asked for by one of the chief scientific advisors of the UK. And so we looked at the risk of hematological and vascular adverse events. So this report we published a couple of weeks ago. And what we've been doing, and what that means, in effect, what we were able to identify was an increased risk of idiopathic thrombocytopenic purpura with the Oxford AstraZeneca vaccine of the risk of the order of approximately 1 per 100,000 doses. What we've now done, and this is unpublished data, is worked with the DAC-VAP consortia, and these are the partners, absolutely fantastic across the UK. These kind of data diagram, but I'm not going to dwell on that. These are unpublished data at the moment, so really they're getting their first hearing. We're writing this up for publication. But across England, Scotland and Wales, we've been able to do a meta-analysis of Oxford AstraZeneca vaccine and the risk of ITP. And what you're seeing there is really a very consistent signal there. So we've actually now been able to replicate across countries, which is absolutely fantastic. In terms of work that's ongoing, we're looking at first and second dose vaccine breakthroughs. Worldwide, we're doing work on vaccine effectiveness in healthcare professionals that will be released pretty soon. Working together with Julia and the Q-COVID team, we're working on post first dose vaccination neurological adverse events. Again, that's pretty close to completion. And then UK-wide, we're working on waning. And lots of people to acknowledge it's been an absolutely fantastic team effort, some wonderful colleagues, really. And please feel free to get in contact if I could be of any help. And Near, I hope I stuck the time, so I'll stop screening. Thanks.
Fantastic. Thanks very much for keeping to time, Aziz. Really, really great. So we'll come back to questions for you later on. Let me just move on straight on to the second talk. That's from Professor Paul Elliott, who's Professor of Epidemiology, Public Health Medicine at Imperial. And Paul has been leading the REACT study. He's going to tell us about this. Also congratulate Paul on his recent honour and the Queen's Birthday Honours list. So Paul, thank you.
Thanks a lot, Munir. Can I have the first slide, please? I don't see the slides. Oh, thank you. Yes, thanks a lot, Munir, and it's a great pleasure to be at this meeting. And I am indeed going to talk about the REACT studies. That's both REACT 1 and REACT 2, and some of the work we've been doing looking at vaccine within those studies. Next slide, please. So REACT 1 is running every month to look at the distribution of and prevalence of viral infection across England. It's based on a random sample of the population across all of the lower tier local authorities in England. And each month we go to around 100 to 180,000 people. We collect a swab for PCR testing for the virus, and that allows us to look at the change in the virus over time so that we can estimate the R number and also look at the prevalence of infection in different socio-demographic groups, by ethnicity, household size, and so forth. And we've also been collecting data on vaccine status, asking people about their vaccine use, and we're currently in the situation that we're awaiting data linkage to the national data on vaccine. And to date, over 12 rounds of REACT 1, we have involved 1.8 million people across the country. Next slide, please. Just picking up on what Aziz said about the Delta variant, these are data that we've been collecting within our own study, where we've been working with COG UK to carry out sequencing of viral swabs that we've obtained in the study. And you can see there April, May, June. So June, end of May and June is the most recent survey that ended on the 7th of June. And the 11th round was from April to the beginning of May. And what you can see there is a smooth spline across the individual data points where we have sequence data. And we, even within the most recent round, as I say, from 20th of May to 7th of June, we saw a big transition where Delta became by far the predominant variant across the country. An estimated 60% of sequences were Delta variant at the beginning of the last round, and by the end, over that short period, it was 90%. Next slide, please. Next slide, please. Thank you. And what we've done is looked at the relationship between testing positive in REACT 1 and the hospitalization and death rates which are obtained from Public Health England. And at the top is that relationship for deaths. At the bottom is hospitalizations, going from our first round of the survey, which was way back in May of last year, all the way through to round 12, which, as I say, ended on the 7th of June. And the red line is mortality in relation to the black line, which is the smooth prevalence of infection across our 18 months of the REACT 1 survey. And what you can see at the top is that there's been a dissociation between the close approximation between infection and later mortality. And what we've done is shifted the mortality curve back to superimpose those curves. And you can see that from around February of this year, there was a dissociation between the mortality curve and the prevalence curve in black. And at the bottom in blue, you can see the hospitalizations. Again, from around February, there was a dissociation, but there's been a reconvergence in the most recent period. Next slide, please. Next slide, please. And if we now look at the same data, but this time stratified by age, those under the age of 65 and those 65 and above. Looking at the top curve, the mortality curve, you can see that there is at both ages still a dissociation, but possibly a coming back together under the age of 65 of the mortality curve with the infection curve. And then if you look at the red line in 65 and over, there's a continued divergence. And clearly, those over the age of 65, most of those people, the large majority, vast majority, have been double vaccinated. Whereas under 65, either people have not been vaccinated or they've had one dose, and a smaller proportion have been double vaccinated. When we look at the blue line at the bottom, again, over the age of 65, we can see that divergence between the prevalence of infection and the hospitalization. If you like, a weakening of the link or an uncoupling of those, of the previously inevitable relationship between infection and later hospitalization. These aren't, by the way, the same people. These are people in our survey against the national data. But under the age of 65, there's a reconvergence of those graphs, which suggests to us that the vaccine, particularly where people have been double vaccinated in the older age groups, is very effective, as we know from other data. But where people haven't been vaccinated, we've got this reconvergence. Next slide, please. And if we look at the self-reported vaccine data under the age of 65 and above the age of 65, or 65 and above, I've highlighted there the younger age group, the prevalence of infection as measured by us in our random survey by vaccine status. And the top two numbers, 0.24%, 0.23%, are those who didn't tell us their vaccine status or they were not vaccinated. And at the bottom of that red box is 2 doses of the vaccine, and actually a few people actually had more than 2 doses. And you can see there, there is still infection, but it's much, much lower, about less than a third than we get in the unvaccinated people. And similarly, over the age of 65, around 0.06% in the vaccinated group are testing positive. Again, giving good evidence for the effectiveness of the vaccine. This is against infection. Next slide, please. Moving on to REACT-2, it has a similar design based on random samples of the population of England at lower tier local authority level. And here we've been sending out test kits for home testing for antibody using a lateral flow device to between 100,000 and 190,000 people per round. And we've tested our device extensively against lab-based testing, ELISA testing, and carried out a very large program of public engagement and how to use the test and the acceptability and usability of the test. And we're using these data on antibody thresholds. So the test gives you a positive or a negative reading for antibody against the S protein to look at prevalence of past infection by sociodemographic groups, and to track the epidemic, this time with antibody levels. But again, we've also been asking about vaccine history, and we will also be getting linkage to the vaccine data, but we don't yet have that in place. Next slide, please. And this slide just shows you that the lateral flow device we're using is actually behaves really quite well against an ELISA test and also against live virus attenuation. You can see in green are the positive and red are the negatives, and there's a strong correlation between virus neutralization and an ELISA test. Next slide, please. just very briefly, this slide asked people whether, in this slide, we asked people whether they either had had the vaccine or would be prepared to have the vaccine. This is back in our 5th round of the survey, which was January to February. And so things have obviously moved on. But you can see in the blue bars that there was very high vaccine confidence in all groups, slightly lower in some ethnic minority groups, which is the 3rd set of bars, and slightly lower on the right-hand side amongst care home workers and healthcare workers, which was well reported at the time. Next slide, please. Now, here we've looked at the effect of a single dose of Pfizer vaccine in relation to antibody prevalence, according in grey to time since first vaccine by age. So it goes under 60, 60 to 69, 70, 79, 80 plus. And you can see in the grey smooth curve that the antibody response decreases by age, and also actually after around 30 days decreases over time. But the blue shaded area is if people have had previous suspected or confirmed COVID, and there with a previous exposure to the virus, you get a very good response even to one dose that does not wane in the same way. Next slide, please. And if we look at the numbers on the left is a single dose Pfizer, and you can see in the red bar looking at the prevalence that there is a reduction in prevalence of antibody with age. But after 2 doses, you get a very, very good response, even at older ages. Next slide, please. So to summarize, Delta variant is now dominant across England, really well over 90% of sequence viruses are now Delta. We have seen a divergence between infection prevalence, deaths and hospitalizations, particularly over the age of 65, consistent with the highly effective 2 vaccine doses against the virus in relation to between prevalence and hospitalizations and deaths. But below the age of 65, we have seen a reconvergence of those patterns. And we're very hopeful that the rapid rollout of the mass vaccination campaign to younger ages, adult ages above the age of 18, will be effective in turning that down and getting again a divergence between those patterns. We do see high vaccine confidence, and that's been borne out, I think, by the recent rollout to younger people with queues around the block, people wanting to get their vaccine doses. And we do see an excellent antibody response to vaccination, single dose with prior infection, and to 2 vaccine doses. Thank you. Thanks, Munir.
Thank you very much, Paul. That's great. A huge amount of work there. So thank you very much for that. So let's just move on straight to Julia Hipsley-Cox, Professor Julia Hipsley-Cox, who is Professor of Clinical Epidemiology and General Practice at the University of Oxford. And Julia is going to tell us about data-enabled vaccine research. Please, thank you, Julia.
All right, so thank you very much for the invitation. I'm delighted to be here. So I'm going to tell you about the Q-COVID programme of work that we've been doing to identify patients at highest risk for vaccinations and other interventions. And you'll see on there and of my other roles, and particularly I'm chair of the nerve tag subgroup on risk stratification that was set up for this purpose.
You're muted, Julia.
So having IT struggles here, so thank you for bearing with me. So this is just to acknowledge all the large number of people that we've been working with over the last 12 months from various universities, NHS Digital, Office of National Statistics. But a lot of the work that we've been doing, nearly all the work we've been doing, actually uses data that's been provided by patients, collected by the NHS, and that a lot of the research questions that we've been addressing as well have been informed by our patient engagement partnership with the Centre for Ethnic Health in Leicester, and this work is supported by various funding bodies, including HDR UK. So to take you back about a year ago, so the Chief Medical Officer advised on which patients were most likely to be need shielding and who would be extremely clinically vulnerable. And that was best guesswork based on what we knew about flu at the time. But the CMO quickly identified that we needed to have a data-driven approach to identify those at highest risk of poor outcomes from COVID-19. And this could then be used to sort of inform clinical discussions and identify those people at highest risk for interventions, including vaccines as they became available. And our brief was to develop a model which was a living prediction model which could be updated, because we recognised even back then that there would just be one virus, there'd be variants of concern would be emerging, more knowledge would be accruing about this disease, more and better data will become available, and then again, as has happened, the vaccine and various vaccines will become available. And so the model that we were developing would need to keep pace with all of this. And in order to do this, we've used the Q Research database, which has been running for many years now, but we've linked it to various data sets that you can see on the left-hand side. So we already had hospital data, mortality data, and cancer registry data, but driven by the needs of what we needed to do, we've also now linked to the infectious diseases, SARS results, intensive care, chemotherapy data, the NIMS vaccine data. We're just about to do a data linkage with the blood and transplant service through NHSBT. And then we went live last week with a real-time linkage to hospital data from London, because what this pandemic has shown us is that we need data, we need better data, but we need it quickly and we need it at scale. So to develop the model, we took a cohort of adults, we split them into two, so one part to derive the model and then another one to check that it worked. And then we looked at a long list of conditions that might increase risk of poor outcomes from COVID. And again, this was very driven by patients in terms of what conditions to include on there. And we've had a really active engagement with patients throughout the whole last year. Then we published the model back in October last year in the British Medical Journal, and it was then quickly validated again by the first, I think, study at scale on the new public health data asset, which is run by Office of National Statistics. And that, again, one of the most important things about models is not just how you develop it, but does it work when you take it onto a different population? And that was published in the Lancet Digital Health in July this year. And what that basically shows is that the score works well, it ranks people correctly, and the predicted risks and the observed risks are close. So it's accurate in terms of that as well. And this provided the key bit of information that enabled the Chief Medical Officer's team to basically proceed with the COVID rollout of the COVID risk model, which was then done so the results actually became available in January, and then in February, the NHS Digital implemented the risk model again. I think it's the first time that a risk assessment tool has been implemented at scale across the entire population of adults, and they undertook what we call a bulk risk stratification exercise to identify the top 2% of patients who are at highest absolute or relative risk based on the risk model. And then that enabled us to identify an extra 1.7 million patients to add to the shielded patient list, and who were therefore able to get prioritisation for vaccination. NHS Digital have also produced a clinical decision support tool, which doctors and patients can use, or clinicians and patients can use, sort of in the consultation to individualise patients' risk, so that they can make individual decisions about workplace and other life choices. So the model that we've done, again, it's not the first risk model we've ever done, but it's the first one of this type, and certainly the first one we've done at this speed and this scale. And it's now in yesterday's NHS data strategy, it's a case study within that as a way forward for using this sort of data to drive improvements in the future. And then we've also released it through Oxford University Innovations onto GitHub for transparency purposes, and so that people can build on the research and see how everything is done. But again, I come back into the point in the middle here, which is this is only possible through the use of excellent high quality data collected as part of routine care. So today, in fact, published in the Lancet Infectious Diseases is our paper looking at what we call the new variant, but I think it's now just become the old variant, or the alpha variant essentially. But this just illustrate how through the data linkages that we've got, we can answer questions really quickly and at scale to look at what the outcomes are for people who had the alpha variant compared with the original variant, and look at the risk associated with being admitted to critical care and to dying with the variant. And what that showed is that there is a higher risk associated with hospitalizations and critical care. But then once you get onto critical care, the outcomes are very similar to the old variant. And then I'm just moving on to the last slide, which is very much active work in progress, nearly completed, which is, as I mentioned at the beginning, we had to adapt the model. So we've done QCOVID-1, which is the first one published in BMJ, QCOVID-2, which was looking at the unvaccinated population in the second wave. So that work is completed. And then we're now already on to QCOVID-3, which is to look at the outcomes for patients who have been vaccinated, but to help identify those who may still be vulnerable despite 1 or even 2 doses of vaccination. And this is using a similar modelling approach, but is obviously restricted to the very large numbers of patients that we've got now who are vaccinated. And this is important because it will not only give us information about the natural history, building on the work that we've just heard in the last talk, but with clinical outcomes related to dose of vaccination, whether you've had prior infection before vaccination, and then the time intervals between the vaccinations. But it also allows us, through the data linkage that we've got getting with NHS blood transfusion service and with the chemotherapy data sets that we've got, to actually drill down and look at what are which of the patients which are still vulnerable despite vaccination, and drill down even to individual types of medication that they may be taking. On top of this, there's a parallel stream of work which is going on at the moment, which Aziz just mentioned, which is looking at the vaccine safety. So we have about 40 different outcomes which we're looking at, and we're probably about a quarter of the way through that work at the moment, with several papers that have been submitted. But we've chosen for this to really publish the results of that once it's been through the peer review process. So more news on that soon. And then that takes me to the end, and I'd lost track of time, but I hope I've not gone too much over my 10 minutes.
Thank you very much, Julia. That's great. If you can, Paul, if you can stop sharing screen, if that's okay. Brilliant. Okay, so maybe I can have the cameras on of all the speakers so we can go into the discussion section, if that's okay. So thank you very much for 3 fantastic talks with different ways of being able to look at things using different data sources and so on. Highlights the importance of data really to be able to understand what's going on during the pandemic, but also in terms of interventions as well. So the first question really is from the PPI panel, and it's to all speakers, and I'll come to you, Julia, first, and then maybe Paul and Aziz in reverse order. The question is really, to what extent has the involvement of patients and the public kept pace with the acceleration of data science during the pandemic? Okay. So Julia, first of all, you.
So we've seen an explosion in the patient engagement work that we've been doing, and that patients have been engaged really from contacting us with the questions they need us to answer, through to actually how we write our grants, and even down to when we're deciding in meetings what's our next outcome of interest that we should look at, for example, on the safety front. We're going back to patients and they're coming back to us really quickly to help with the prioritisation of the work that we need to do. The work that we've done with the Centre for Ethnic Health has been great, because they're able, obviously, I haven't mentioned much about the diversity and ethnicity work that we're doing, funded by the MRC, but again, that's a sort of cross-cutting theme against all of the work that we're doing. And there's been obviously a big impact of COVID on different ethnic groups, and it's so important that we actually keep pace with what the questions are, but also how to communicate back. So we've had, through the work of Sharon Dixon in Oxford, better and closer coordination with patients throughout all of the work that we've just presented and all the rest we've done in the last 12 months.
Thank you. Thanks very much, Julia. Paul?
Absolutely agree with Julia. It's been completely critical to all our work from the very beginning. We involved patients and the public in, particularly in the work we're doing with the lateral flow device. We had a panel that was looking at different devices, instructions, how to use things, and then actually took part in small pilots to see how we could improve presenting a home test, which, as you know, Munir from the MHRA, I mean, had to go through a special process of approvals to be able to use a home test in that way. And then we had pilot studies that went to very large numbers of thousands of members of the public who then gave us feedback in sort of in an open way, so that we could again improve matters before we launched the whole study. So it's been absolutely critical to that work. As another example, we have a study on long COVID funded through the UKRI NIHR program, and that there we're being very much guided in the design of our study, how we're approaching people, what sort of symptoms we should be looking for, and using the patient experience to guide that work. So like Julia, I'd say it's been absolutely critical to the work and the success of the work.
Thank you, Paul. Aziz?
Yeah, very similar, completely echoing Julia's and Paul's comments. So both with EEVE-2 and the fact that patient public involvement is baked completely into this, prioritising questions, getting involved in the actual research. We have members of the public who are on the actual papers, so they're co-authors with us. They then work to help us disseminate, so we're producing lay summaries, infographics. Members of the public are heavily involved. I think it's vital that we do this, and the pandemic has accelerated this for us.
Thank you very much. So to the members who are listening, if you do have questions, then please do put them in the chat, and I will get to them as soon as I can. So the next question really is from Caroline Cake, who's Chief Executive of HDR UK, and it's to address to all three of you. And maybe Paul, you can take it first. Great to see all the powerful data and the resources and what we've done within COVID. But what are the implications for future vaccination programs, for example, flu and so on? So Paul.
Yeah, I think we're very keen that the work we're doing isn't just, if you like, of the moment, because I mean, I think you've seen from all three speakers that we're feeding in results in real time. We're working a very, very different way to what we normally would do in epidemiology or public health. And we're feeding back results sort of in real time. What we want to do is make sure that the learnings that we've got from setting up these very large programs, how to monitor vaccine, how to monitor health, in relation to an epidemic or a pandemic, that we learn the lessons. So this is something that we're very focused on, and we will, hopefully that there will be infrastructure and future work continued beyond this initial pandemic that will allow us to do exactly that and monitor future infections and future vaccine rollouts.
Okay, thank you. So obviously, general practice is the epicenter of this of flu, vaccination programs and so on. So Aziz and Julia, maybe you want to come in and comment on that as well.
Yeah, so I think Caroline, as I sort of mentioned in our presentation, we've taken the learnings from flu, pandemic flu, and also done this work in seasonal flu across Scotland, working hand in glove with Public Health Scotland as a core partner. So, and I think we've tried to take that learning and apply it to COVID. I think, where do we go from here? Well, what would be really useful to be able to do is to do replication work in other countries. And I think that the fact that we do have sort of devolved administration should make that possible. And I think that's the one thing that's possibly being accelerated for us.
Julia?
Yeah, so we've just we've been running real-time surveillance systems in Nottingham and Oxford for the last 15 years, but at a very high level. So just sort of similar simple counts of things. And I think where we are now is just there's a massive need for event granular level data, where you can look at, particularly for vaccine safety, where you can look at events being sequenced, sort of, you know, a vaccine and an event and another vaccine, which you have to have much more granular data to do it, and you have to have that much more quickly. And so again, one of the things I mentioned in my presentation is that we've been able to secure, really for the first time, real-time hospital data, rather than waiting for patients to be discharged from hospital and then 3 months later finding out that there was a problem. Now we're in a situation where we can actually get real-time information, not nationally but regionally, from hospitals, so we can see if patients are having vaccines and then going into hospital. We can see what those problems are without having to wait 3 months. So that's very early days, but new work, and I think it's totally essential. And I think my own feeling is that because of the public generally can see the benefits of actually and the need for us to be able to monitor and look at things like safety and effectiveness of vaccines in real time. And they can see probably for the first time tangible ways in which sharing the data can actually benefit people, because of highlighting, you know, your increased risk, therefore you should have your vaccine sooner, or you should have, you know, maybe as monoclonal antibodies become available or other interventions become available. There's going to be a lot closer connection between the research that comes out, how it's implemented, and patient benefit. And instead of taking years, then that's going to be, you know, done in weeks or a few months. And so I think there's been some, you know, obviously terrible things that have happened because of the pandemic. But I think part of the legacy about this is that we've got a lot smarter and a lot better with how we use and handle data.
Great, thank you very much. So maybe I can ask some specific questions related to the work that you've been undertaking. So maybe Aziz, start off with you. There is a question here about second dose of AZ and the risk of thrombocytopenia, particularly in the younger age groups and so on. So I don't know, your data was mostly focused on first dose and the risk of thrombocytopenia, and don't know how far you've got with looking at particularly second dose, or with the signal second dose as well.
Yeah, we've not done that analysis yet. It is on the kind of rather long list of things to do, Munir, but yeah, but we don't have any answers to that at the moment.
Okay. Paul, in terms of vaccine confidence, obviously we are now vaccinating under 30-year-olds, and there's quite a lot of worry that maybe their vaccine uptake won't be as good in the sort of younger age groups, and you know there may be potential for vaccinating you know, teenagers and over children above 12 and so on in the future as well. So I don't know whether your work has looked at vaccine confidence for the sort of younger, you know, 20s. But also, you know, whether it's also touched upon if we ever need to vaccinate children.
Yes, Munir. So I did show a slide that did show that the vaccine confidence was a bit lower in the younger people, but that was very, very early on in the rollout and before younger people, unless they were, you know, at risk, were being offered the vaccine. We haven't yet published data, so I can't show it to you, but we have done now round 6 of REACT-2, which was later on, so that we have much more recent data that we'll be able to look at that. But again, before this latest rollout, and we will be tracking it also through our REACT-1 study, which it goes in the field again end of this week. So we will be collecting data on this, and it is very important. But I certainly have been heartened by seeing what's been happening when people have been offered it. There are big queues around the block to get the vaccine. So I'm quite hopeful that people will take up the offer of the vaccine. It is really, really important that they do that.
Great. Thanks very much, Paul. Julia, you said you're now working on a new score to be able to determine who gets a booster dose, you know, in the future, and there's quite a lot of discussion about that. So I don't know whether you want to elaborate on exactly how you're planning to do that and what you're going to look at.
Okay, so we've taken a cohort of patients who've been vaccinated, starting and then following those patients through over time from their first dose, and then separately looking at their second dose, and then looking at the outcomes of who has a COVID-related death, sadly, after a vaccine, and who has a COVID-related admission. And then we're factoring in to that all the risk factors that I put onto my slides earlier, but also calendar time and infectious disease prevalence of the SARS-CoV in the community. And then there are some emerging findings from that, which are just slightly too preliminary for me to show today. But there are groups which are emerging for whom some of the vaccines, they still are vulnerable despite having had some of the one or even sometimes two of the doses of the vaccine. And then potentially that could be used in a similar way to the first bulk stratification, to basically flag people who are at the top, maybe 1 or 2% of highest risk for vaccine breakthrough. And so those patients potentially could be informed. And then as the policy comes on, and obviously I don't speak for the Department of Health or anybody about policy here, but should there be a policy, a decision to do booster jabs, etc., then this is the sort of information that could help target those patients, obviously in discussions with other factors and JCVI and so forth. And so that's how that's working. It's working at pace at the moment, and so we are hoping to have something which is paper submitted and tools ready to use it by the autumn. So that's how we're planning to work on that.
Great, fantastic. So the alternative may be to say, well, actually, let's just vaccinate everybody above a certain age. And Aradazi wrote an article in the Financial Times suggesting that maybe we should do antibody testing and just do, vaccinate those where the antibody levels are not high enough. So, and Paul, you've been doing antibody testing and so on. So I know your perspective on that in terms of the future booster vaccination campaign.
I think it's a bit of an open question. Actually, just to declare an interest, Aradazi is one of our co-investigators on the program, and this is something we're actively discussing. I think that we do need more work to understand how this might work, because what we don't know yet is the extent that having waning antibody levels, whether you're still protected or not. Part of what we're doing in the REACT-2 program is linking our people to future hospitalizations by antibody response, and I think that those data will be really important. So that data linkage is going to be really critical to understanding the extent that antibody level post-vaccine is a biomarker of future risk, and I don't think we really know the answer to that yet.
Okay, thank you. So just to finish off, a last question maybe to you, Aziz, and really, what is the most important thing for the sector really to do when shaping the post-pandemic landscape for health data science?
Yeah, thanks, Munir. I mean, I think we need to take, all of these learnings, the fact that we've got data flowing, the infrastructures that are being created, and apply those to, all sorts of other disease areas. Because so much of the time, policymakers are just operating absolutely blind. But why can't we, take this learning and apply it to cardiovascular disease, diabetes, cancer, whatever really. So this can't just be a flash in the pan. It can't be a one-off. It has to be moved to something sustainable to help improve outcomes across the piece, I think.
Okay, that's a really important message. There are hundreds of other diseases out there that we need to be able to use data really to be able to improve the outcomes for our patients. So thank you very much, three of you, for those fantastic talks and answering questions, and for the audience for joining us, and for HDI organizing this session. So thank you. It's 11:15 and time for coffee. So thank you very much, everybody.
Thank you.
Thank you.